Good evening, everybody. Everybody, I say. I'm Dr. Carrie Riestenberg. I'm one of the reproductive endocrinology and infertility specialists here at Coastal Fertility. And tonight I'm excited to have the opportunity to talk to you all a little bit about polycystic ovary syndrome in honor of PCOS Awareness Month. So I'm going to talk a little bit about what PCOS is, the diagnosis of PCOS, what that means, and then a little bit about, how we take care of patients with PCOS and, treatment and options for growing and expanding your family as a patient with PCOS. So just to start off, the diagnosis of PCOS, or let's talk let me back up even further. So PCOS is polycystic ovary syndrome. The name of PCOS is actually something that has been, controversial over the years and is currently, there's actually an active debate about kind of renaming PCOS because it is a little bit of a confusing misnomer. When patients think of polycystic ovaries, they think that these cysts are abnormal things or that they're pathologic, and really what I want to let you know is just that polycystic just means that you have a lot of follicles in your ovaries. Follicles are small fluid pockets that we can see on transvaginal ultrasound. Each follicle contains generally one microscopic egg inside. And so polycystic really just means that you have a lot of these follicles in your ovaries. And we'll talk a little bit about what a lot really means, but it doesn't mean that you have, dangerous cysts or abnormal cysts. You just have a lot of follicles. So that's a little bit about the name. In terms of the diagnosis of PCOS, so PCOS is the most common endocrine disorder of women of reproductive age, and it affects actually 8 to 20% of women of reproductive age, depending on which diagnostic criteria you use. So it's extremely common. That means up to 1 in 5 women, young women, have this diagnosis. There are 3 different diagnostic criteria that are used to diagnose PCOS, but by far the most common is the criteria called the Rotterdam criteria. And the Rotterdam criteria are pretty easy to apply clinically. And you can use them to kind of assess yourself and see if you might be someone who you think may have PCOS. So the criteria requires 2 out of 3 things to be present in order to meet that diagnosis. The first, and one of the things that brings a lot of patients to us, is irregular menstrual cycles. So if from the first day of bleeding in one cycle to the first day in your following cycle is not within 21 to 35 days, then you're considered to have irregular menstrual cycles. And that is the first diagnostic criteria. Second criteria is clinical signs of elevated androgens or male hormones, meaning hair growth on the upper lip, chin, lower abdomen, or back, alopecia, so hair loss on the scalp, and acne. So that's clinical signs of elevated male hormones or having elevated male hormones in the blood, so elevated testosterone typically. And then lastly, the third diagnostic criteria is having what we consider to be polycystic ovaries on transvaginal ultrasound. And obviously this requires an evaluation with either your OBGYN or fertility specialist. And what polycystic means is just having 20 or more follicles in one or both ovaries or more, or an ovarian volume of 10 cc's or more. So having large ovaries or ovaries that have more follicles than we typically expect. So that's the diagnostic criteria that we typically use. So also important to understand, patients with PCOS are born with PCOS. They may not display the symptoms or have the symptoms when they're younger. They may be more identifiable as they get older. And in fact, we don't often diagnose PCOS in young women because so many of the symptoms of PCOS are actually totally normal in adolescents and teenagers. So irregular menstrual cycles can be normal. We know acne is really common, right? We've all been there. So this is something that we really only diagnose once you're kind of reached maturity, and we define that as 8 years after your first menstrual cycle. Once PCOS has been diagnosed for you, it's important to know the long-term health risks that you're at an increased risk for. So diabetes, so insulin resistance, pre-diabetes and diabetes is a really important one. And if you have this diagnosis, you should have at least an annual evaluation with your primary care physician or your OBGYN, looking at either your hemoglobin A1C or doing a glucose tolerance test to look for evidence of pre-diabetes or diabetes. Because of this, women with PCOS, and most commonly overweight or obese women with PCOS really benefit from going on a medication called metformin. Metformin is an insulin sensitizing agent, so that means it just helps make your body more sensitive to the insulin that your pancreas is already secreting, and really helps prevent the progression from normal to prediabetes or prediabetes to diabetes. So, okay, so we talked increased risk of diabetes is one risk. Another risk is cardiovascular disease. So a lot of women with PCOS tend to suffer from obesity. They can have higher levels of cholesterol and other abnormal lipid levels, and this predisposes you to an increased risk of cardiovascular disease. Very important to check in annually again with your PCP or OBGYN to do recommended screenings and to discuss things about lifestyle like diet and exercise that can help reduce the risk of developing more significant cardiovascular issues down the line. Women with PCOS are also at increased risk of obstructive sleep apnea. So if you feel like you're, particularly fatigued, or if your partner says you are really snoring a lot at night, or maybe you stop breathing altogether, this is something to talk to your doctor about, and you may benefit from screening for obstructive sleep apnea. Anxiety and depression. So mental health is actually often not talked about. I feel like that's often left out of the discussion, but women with PCOS are at increased risk of anxiety and depression. And so if you have PCOS and you're suffering from either of those, know that you do have an underlying predisposition to those, and, really important to talk to your doctor about that and seek help. And there are, great medications available and that are also safe during pregnancy. Finally, women with PCOS are at an increased risk, about a 2 to 6-fold increased risk of endometrial cancer. That's uterine cancer. And the reason for that is that, and we'll get into the fertility aspect, but a lot of women with PCOS have irregular cycles, and the cause of the irregular cycles is ovulatory dysfunction, so not ovulating on a regular basis. If you're not ovulating on a regular basis, that means that your uterus is primarily being exposed only to estrogen. So your ovaries are making estrogen, all of our fat tissue makes estrogen, and the lining of the uterus just sees estrogen, 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 and the lining grows and grows and grows. And over time, it can become unorganized, disorganized, and eventually turn into hyperplasia, which is a precancer. And in the very long term, it can lead to an increased risk of endometrial or uterine cancer. So very important. I tell all my patients with PCOS that during times when you're not trying to conceive, it's critical that you have some kind of bleed, whether that's on your own or induced by a hormonal medication, at least every 3 months to keep that risk down and normal for you. So those are kind of the long-term health risks that women with PCOS are at increased risk for, and things to talk to your doctor about and that you should be screened for annually. But let's talk a little bit more about fertility, my favorite topic. And this is really why we meet a lot of our patients with PCOS. So patients will come to us having difficulty getting pregnant or trying to track their ovulation with ovulation predictor kits at home or using their apps on their phone, using basal body temperatures, and finding it extremely frustrating. There can be a lot of false positives with these tests, and really it's very hard to determine when a patient with PCOS may be ovulating because it doesn't happen on a regular basis like it does for women with regular menstrual cycles. So that's when we generally meet a lot of our patients with PCOS. One thing I would say is that if you have PCOS or think you may have PCOS, don't wait. Don't spend 6 months to a year trying on your own. Talk to your OBGYN and come see a fertility specialist right away. There's no, no need to waste time when you really could benefit probably from a little bit of treatment. So ovulatory dysfunction is the major cause of infertility in women with PCOS. And what that means is that those ovaries, your ovaries with all those beautiful follicles in them, are just sitting there. They generally just sit there at baseline, and they're not growing a follicle that ultimately would rupture, releasing the egg and giving you a chance for fertilization. That process just doesn't happen as regularly for women with PCOS. So what we typically do is we do a full fertility evaluation for all of our, patients and couples with PCOS to make sure there's no other identifiable infertility factors. What that means is generally doing a pelvic ultrasound to look at the uterus and the ovaries. We do some hormonal blood testing. We generally do a hysterosalpingogram to look at the inside shape of the uterus and at the fallopian tubes. And then we do a semen analysis if you have a male partner. If the only thing that is abnormal is your diagnosis of PCOS, then the great news is that you get to do the least invasive, least aggressive treatment option that we have for any patients that we see. And that would be ovulation induction with timed intercourse. So that treatment generally involves bringing you into the office for a baseline ultrasound. We typically do ovulation induction with letrozole, or Femara is the brand name of the medication that we use. That medication has been compared to Clomid, which is the other common oral medication. They've been compared head-to-head in a randomized controlled trial in women with PCOS, and letrozole was found to be superior in terms of having a higher success of inducing ovulation, a higher live birth rate, and a lower chance of multiple gestation, lower chance of twin pregnancy. So we generally will use letrozole as a first-line treatment for these patients. We'll give you letrozole. This is a pretty inexpensive medication that you can get from a regular pharmacy. We bring you back after taking the medication, do an ultrasound and look at the ovaries and make sure that the ovaries are responding. And what I mean by that is that we want to see at least one of those small follicles growing large. We may need to monitor you over a couple of ultrasounds as that follicle or follicles grow larger, and then either your brain will send the message for ovulation on your own, or oftentimes we'll need to induce ovulation with a ovulatory injection medication such as Ovidrel. Then we'll tell you guys exactly when to have intercourse if you're having intercourse, or when you'll need an insemination if you were using, inseminations, if there is a male factor component, or if you're using donor sperm. And patients generally have about a 15 to 20% chance of pregnancy per month. So that's just natural fertility, unless there are other, other contributing factors. But we do this treatment for 3 cycles or so, and then we may regroup if we're not successful at that time. But it really is reasonable to continue this treatment for up to 6 cycles or so in patients with PCOS. Success rates are quite good. The majority of our patients will certainly be pregnant by 3 to 6 months of treatment. If we aren't successful, meaning we aren't able to induce ovulation with letrozole, which happens in some women with PCOS, they have some resistance. Their ovaries are a little bit resistant to ovulation induction. We may either do a trial of Clomid, so try a different oral medication, or we may recommend adding a low dose of an injectable fertility medication called Gonal-F, which is a gonadotropin. Most women do respond to some of those interventions. And if not, if we really have given this a good shot and we're not able to get you to ovulate on your own, then we may recommend a conversation about IVF. But the vast majority of our patients with PCOS will be successful with pretty limited intervention, which is why, come see us. Don't be afraid. I know it's really intimidating and can be anxiety inducing, but a lot of the time we can really help with minimal intervention. Let's see here. Other things. So I get a lot of questions from my PCOS patients about lifestyle, diet, and exercise, and that's a really important component of our counseling. Women with PCOS do have a different metabolism. So I tell all my patients with PCOS that if you and your sister ate exactly the same. You have PCOS and your identical twin sister does not have PCOS. If you guys ate the same and exercised the same, she would lose weight and you would not. So the difficulty with weight loss is a true thing. And I know that a lot of my patients experience kind of negative commentary about their weight or their, difficulty losing weight from physicians and, friends and family who don't understand that your metabolism truly is different. So I get a lot of questions about how do I lose weight? What is the best diet for women with PCOS? And, studies really have not found that one diet is particularly better than another. I will say that in general, there's an increasing body of evidence that a whole food plant-based diet, rich in vegetables and lean proteins and lower in processed carbohydrates is good. It is good for weight loss. It is good for reducing inflammation in the body, which overall is really beneficial for fertility and PCOS in general. So that's what I recommend to my patients, a whole food plant-based diet, lots of vegetables, lean meats, fish, chicken, and less processed carbohydrates and sweets. For exercise, I recommend finding whatever you enjoy doing and do it for 30 minutes a day, 5 days a week, whether that's walking around the block with your dog, whether that's high intensity interval training, whether that's, Peloton, swimming, whatever it is. If we can be active and move your body 30 minutes, 5 days a week, that's really our goal. And then there certainly are some really remarkable, medications out there to assist with weight loss management, and you may be a candidate for those depending on, your particular health history and where we are in terms of weight. I'm happy to initiate that conversation, and we often will have you follow up with your primary care for management of those kinds of medications, but a lot of patients can benefit from those as well. Let's see here. Any questions, Holly, or not yet? Okay. Okay, so treatments for patients who are not trying to conceive right now. Okay, that's another good topic. Birth control pills. So I know probably a lot of you are overhearing about birth control pills. I have a lot of PCOS patients who, feel like, well, all my doctor ever tells me to do is go on birth control. So, I want to explain why it really is such a great treatment for women with PCOS. It does a lot of things and it's very good at doing them. So number one, birth control pills will regulate your menstrual cycle and protect you against uterine cancer. So combination oral contraceptive pills, the ones that have estrogen and progesterone, have that important component of progesterone that protects the uterus against uterine cancer. So number one, keeps you safe from uterine cancer. Number two, prevents unscheduled bleeding. Okay, you can have a bleed every month on these birth control pills. You can have a bleed 3 times a year on these birth control pills. Either one is totally fine. Number two, birth controls are one of the most effective treatments at treating the other symptoms of PCOS like acne, hair growth, and hair loss in the scalp. They do this through a few different mechanisms. One of the most important is increasing a protein called sex hormone binding globulin, which it does by acting at the level of the liver. Sex hormone binding globulin binds all of the sex hormone, particularly testosterone that's in your blood, and it makes less testosterone bioavailable or available to cause all those symptoms that you're having, acne and hair growth. So it's very effective at that as well. To see the benefits of being on birth control pills, you really do want to give it 3 to 6 months because the cycle of the hair growth from the follicle is about 3 months long. But for those reasons, birth control pills are really great for a lot of management of PCOS symptoms. Metformin we already briefly touched on, but that's a great one to add on that can help from a metabolic standpoint and reduce the risk of development of prediabetes and diabetes. And then some patients, depending on how you do after starting birth control, you may be a candidate for other medications like spironolactone or other anti-androgenic medications that will also target hair growth and acne development if the birth control pills are not doing that adequately for you. And then, you know, obviously there's always laser and wax and other things that are available, but, you know, there certainly are some medical management options that are very effective. So, you know, those are also things you can discuss with your OBGYN or us in the office. Let's see here. I'm trying to think of anything else that I didn't touch on. Yeah, I think, you know, PCOS from, you know, just how does one get PCOS? There is a genetic component, absolutely. You will see, you know, this run in families. I just saw a patient today who, you know, she didn't know she had PCOS, but her sister had PCOS. So it certainly has a genetic component. There are also environmental components and lifestyle factors as well. So it's what we call multifactorial, meaning that there are a lot of different things that can contribute to the risk of you having PCOS. It's not something that we can cure or get rid of, but with appropriate management, both kind of lifestyle management and medication management, it can really be managed, and that's really what we want to do. We want to reduce the risk of developing any of these long-term comorbidities and help you, you know, grow and, you know, start and grow your families without too much delay. So I think that I'm going to go ahead and conclude it there. A, you know, really important topic. It, you know, is very, very common. So if you think you may have some of these symptoms, that you may have PCOS, don't hesitate to call your OBGYN, call us, come in for a consultation, and so that we can get to the bottom of it and get you the care that you need. Okay. All right. I think that is probably it. No questions. All right. Okay, everybody. Thanks for tuning in. Feel free to give us a call at Coastal Fertility if you want to, you know, come in for a consultation. We'd love to meet you. Take care. Bye.